We're good.
Okay.
Good.
So welcome everybody. So I want to thank Russ and Joe and the rest of the board of Eastern Allergy for inviting me back. Now this is our 15th year that I've been able to have the honor to participate in integrating problem-based learning cases into the Eastern Allergy Conference. I think we have kind of a unique situation down here that at the Breakers, in which we've had many years of having a problem-based learning case that we discuss interactively, where everyone gets a chance to speak and give their opinions about how a case evolves as it would in your office on Monday morning at 9 a.m. And then after giving his or her opinion and we work through the case as a group, everyone getting a chance to speak and no one dominating or taking over. So we all need to be polite and give everyone a chance to speak. Then you get back into your post-PBL lecture hall after the coffee break. And during the post-PBL lectures, one of the lectures will be in context to this case. And the lecture, which will be done shortly thereafter by Karen Blattman, will be about this case and her take on all the different aspects that you will discuss. And so she may correct some misinformation. She may add some information that you weren't aware of. And then she'll also do a more detailed lecture about the disease state. But I think the most important thing that is done at Eastern Allergy, which is fairly unique, is that the lectures are not just an abstract lecture, they're in context to the case that you just discussed. So it helps reinforce the importance of the diagnosis and treatment of the case we're gonna work on. I have disclosures that I have in the booklet that was published. They're, I don't think, very relevant to today, since even though I work with pharma companies with problem-based learning, teaching problem-based learning, I'm really not going to comment on any therapy. So, so again, I think we need to delve into the case. Everyone needs to jump in and give his or her opinion and help out as much as you can. So this is a group endeavor. The more you put in, the more we'll all take away from this case. And I, as a facilitator, will help guide you through, but I'm not going to give my opinion, but I always pick up some pearls from you, from the group. Grant is going to be our IT expert. And just to run down the list, Joan introduced herself as a retired allergy immunologist in from New Hampshire.
Well, first of all, I'm not retired. I'm supposed to be retired, but I'm
Joan. That was Joan.
Joan
Yeah.
from New Hampshire. Joan Cassateri is retired from New Hampshire, and Sheila is from Atlantis, Florida. She's allergy immunology. Charlene just introduced herself, and Joe Belanti. Not Joan, but Joe Belanti is emeritus professor at Georgetown and needs no introduction to any of us because he is definitely a legend to all of us, and we're so happy to have him as part of the group. So I am a professor in clinical pediatrics at Washington University School of Medicine and in a private practice for the last 38 years in St. Louis, and do allergy immunology as well. So if we can get started and turn to the first slide, Grant, and if someone would volunteer to read out loud the first page of the history of the present illness.
Alex is an 18-year-old male, is referred to your office by his pediatrician for food getting stuck in my throat, quote. Over the past 4 years, he's noted intermittent difficulty swallowing certain foods, especially meat and bread. He also complains that ingestion of apple makes my mouth and throat itchy, again a quote. His symptoms seem to worsen in the spring in conjunction with his seasonal rhinitis.
So how do you interpret this information?
So he definitely has some oral allergy syndrome with itching of the mouth with apples, maybe other fruits as well.
What do the rest do you think?
He has this dysphagia, sounds like dysphagia, food getting stuck. Seasonal, right, seasonal allergies.
Okay, seasonal allergies, oral allergy syndrome, it sounds like. Dysphagia. What do the rest do you think?
He also has allergic rhinitis.
Okay. Which certainly would fit with his oral allergy syndrome. So what would be your differential diagnosis just from the get-go? Just if you saw him at 9 a.m. on Monday morning, this was the first few sentences of what he told you he was seeing you for, what would just be your subliminal differential other than what's been mentioned?
Consider reflux.
Okay. GERD? What else?
EOE, esophageal
EOE?
spasms.
Okay. EOE, esophageal spasms. Anything else? So once again, if this were 9 a.m. on Monday morning and this was your first few moments of what he told you his chief complaints were, what questions would you ask Alex to develop his history more thoroughly?
Has he ever had an impaction where he's had to have go to the ER to have removed? And
Okay, so
yeah.
any impaction? What else? What else would you want to know?
He's 18, so I'll ask him, do you chew your food?
He probably inhales his food, right? That's what
Right.
most teenagers do. What else do you want to know?
Symptoms of GERD.
Okay.
Has he taken anything like a PPI, or has he been treated for any GI disorder?
Okay.
Has he ever had an endoscopy?
Okay. So testing. So let's move on to the second page and get just a little bit more history for his next few moments. If somebody who hasn't read could read that page for us, please.
I can go ahead.
Sure, Sheila, go ahead.
Collateral allergic history is notable for seasonal rhinitis and asthma with onset at age 6. Although he was treated with SCIT for 2 years, beginning at the age of 10, he continues to experience occasional mild to moderate rhinitis, which is adequately controlled with PRN non-sedating antihistamines. His asthma has improved with age. He has not needed treatment with prednisone in several years and is currently using albuterol HFA once to twice weekly to relieve chest tightness in the spring and fall. There is a past history of atopic dermatitis as an infant toddler, which is completely resolved. He has no history of other food reactions.
So how do you interpret this information?
He's a very atopic person.
He's a very atopic person. What else? What are your thoughts about his rhinitis? Any thoughts about his asthma? What degree of asthma you're seeing by history? Can you guys hear me okay?
I
Yeah.
can hear you.
Yeah.
What type of asthma does he sound like he has, at least just by history?
Sounds like intermittent asthma.
Okay. So he's been on
maybe.
prednisone in the past. He's had treatment, but at least he seems like he's evolving, as some kids do, outgrowing his asthma to a degree where it's much more mild and more seasonal. Any thoughts about his rhinitis in the first paragraph? Any comments that you want to make? Was treated with SCIT for a couple of years. Maybe didn't have a full course of treatment and is still having some mild to moderate symptoms, but he only seems to need PRN medications, which adequately control him.
It's
Past
mostly
history.
seasonal. I mean,
Yeah.
the word seasonal has come up at least twice now. But it all sounds typical of a person with atopic history.
And then at least there is no history of any other reactions, any food allergy reactions, any immediate hypersensitivity. All right, so let's move on and get a little bit more history. Grant, thank you. So who hasn't read? Charlene, you want to read for us?
Sure. Review of systems, general, good appetite, no weight loss, gastrointestinal. Besides the dysphagia, he experiences some mild nausea with epigastric abdominal pain. He denies heartburn, vomiting, or diarrhea. Respiratory, seasonal rhinorrhea, nasal congestion, conjunctival injection, and ocular itching and chest tightness. Severity mild to moderate. These symptoms are more common in the spring and early summer, but are currently resolved at the time you are seeing him, which is midsummer. Remainder of the review system is negative. Past medical history, negative except as noted above. Environment, no pets or smokers. Social history, Alex is a high school senior. He is actively involved with soccer and band.
So how do you interpret all this information? Sheila, you were concerned about his heartburn and GI symptoms.
Gastrointestinal tract.
What's that, Joe?
You know, with these symptoms of nausea and epigastric abdominal pain, you know, it's focusing now, in addition to the respiratory tract, there's some involvement of the gastrointestinal tract. And that leads us into some of the allergic conditions that we're familiar with. Eosinophilic gastroenteritis has to be considered in addition to others. This will lead into more diagnostic tests that can firm it up more definitively.
Okay. What do the rest of you think? Any other thoughts about this information that this helps reinforce or narrow down? All right, let's go on to the next slide. So I'll read the physical. It's pretty easy. General, well-developed, no acute distress. Vital signs, blood pressure 120/70, pulse 76, temp 97.2. Physical exam was basically unremarkable except some mild nasal mucosal edema and some cobblestone pharynx. So how do you interpret that?
Goes along with the history, his history of allergy and allergic rhinitis.
Yeah, and it tells us that, you know, he obviously has some postnasal drip, and if he does have EOE, that could definitely be a factor.
Okay. So what is the cobblestone throat? What is that immunologically or
This is
pathophysiology?
lymphoid tissue that's stimulated in that region.
Is it specific to allergies or IgE mediated, or is it non-specific?
You can't really tell, but most likely with the history, it's probably related to the allergic inflammation.
Okay. All right, so let's go on to the next slide. So Grant, are you able to type in on this?
Yes, I am.
So who wants to help our group with what you would consider the most likely working diagnosis? Obviously, you don't have any testing, and we'll go on the next bottom of this slide. We'll decide what testing you might want. But at least at this point, what are your thoughts about this patient's most important first initial diagnosis, first impression?
I would put dysphagia, rule out GER, rule out AOE.
Okay, so dysphagia, DYSPHASIA. And what did you say?
That should be a G.
A GI.
Oh, yeah, right. Phagia.
Oh,
My spelling, I don't have spell check.
Dysphagia is your condition.
Yeah, yeah. My bad. All right,
No problem.
what else did you say?
Dysphagia, rule out GER, rule out EOE.
Okay, so I guess what we could do is put on here question mark,
Yes.
put a question mark, and put GERD, capitalized, GERD, GERD. And then maybe number 3, put question mark, EOE, okay? What else do you guys want to put on here?
Seasonal allergic rhinitis.
So put capital AR, rhinitis.
Sorry, you're cutting out.
Just put capital S, capital A, capital R. Seasonal stands for seasonal allergic rhinitis. All right, we're running out of diagnoses. Obviously, there was some history of mild intermittent asthma.
And also the oral allergy syndrome or pollen.
Oral allergy syndrome, or what they also call oral pollen food allergy syndrome
Right.
now. It's been renamed several different ways. Anything else that you would put on there, even though we don't have room?
History of eczema.
History of eczema. Okay, good. So what would be the first thing you would do in your office? Let's say you saw this gentleman at 9 a.m. You've taken a thorough history, as you just did. Now it's about 9:15. Your nurse tells you you've got another new patient waiting in the waiting room who's anxious to see you, doctor. And you need to kind of move things forward and decide what tests you want to do there in your office today. So what would be the first thing that you would order with your nurses or medical assistants?
Well, I'm sure the parents or individual would be concerned about possible food allergies, so I will order a skin testing.
Okay, so this patient had no clear-cut history of any IgE-mediated immediate reactions, but you're saying you would do some immediate hypersensitivity skin testing to this patient?
I would, because in general, when patients come to the office, they expect that. I will do the shared decision-making of saying that I don't think you have an IgE-mediated food allergy, and that there are other things that would make, reason for your dysphagia. But most patients come to the allergist for an allergy skin test to food. Otherwise, they would go to another allergist who would do that. At least in my practice, that would be what happens.
Okay, so that's an interesting point, Charlene. So what do the rest of you think about that? Is this patient, with some shared decision-making discussion, a patient in which you would do, I assume, just a number of food allergen prick skin tests?
Yes.
What do the rest of you think about that? Joan?
I would, I think you said Joan. I would do some, I mean, I know there's some, I don't know if it's controversy is the right word, but whether or not a typical food allergy plays a part, but I think a lot of patients, at least when I saw them, if they had some positive foods and we avoided food, sometimes it did help. So I would do sort of some food testing.
So selectively you would do some food testing, not like 20 or 30 or 40?
I might do maybe the common like food allergens with some other selected foods.
Okay. Sheila, would you do some food skin testing? And if so, which ones?
I would put them on a PPI and send them for.
So hold on for 1 second. We're not talking about treatment yet. We're just talking about evaluation. So would you skin test this young man for foods? And if so, which foods?
So I think he will need some skin testing to foods, and I think it's in this case I am highly suspicious for EOE based on the history. So I would do a skin test to foods that are just known to have a higher tendency to be causative in EOE.
Dr. Belanti, what are your thoughts about skin testing this gentleman for food allergies? And if so, what would you tell your nurse? What food tests would you want, or would you not want any?
Well, the answer to the first question, yes, I would recommend skin tests to the most common foods The most common foods are in a set of eight foods, which are MEW, milk, egg, wheat, corn, soy, fish, and use those first eight. Now, in addition to the foods, there is the possibility that inhalant allergens might be involved because of cross-reactivity with foods. Some of the inhalants, for example, ragweed cross-reacts with different foods, as does birch. So, but I'd start with the eight common ones.
Okay, thank you. Dr. Sedapane, do you have any different
Well, you know, I
thoughts?
think, yeah, sure, certainly. I think there's a lot of expectation on the family's part in terms of this. There was some where they're probably wondering if there's a meat allergy. I think you got to test for foods that the family has concerns about, even though we really don't think it sounds like a food allergy. Additionally, if we're thinking that this could be EOE, I would want to get the foods that have been associated or with EOE. I'd like to get the testing for the soy, the milk, the egg, the wheat, the peanut, tree nuts, and shellfish. So just in case we end up finding out this is confirmed to be EOE, we would have that data up front.
So to be the devil's advocate here, if this patient ultimately has EOE, and the tests were positive to a number of foods, or they weren't positive, does that change your treatment? Does it make you more likely to prescribe epinephrine autoinjectors if they're positive? Or does it change which foods you would eliminate? And we'll get to the treatment at some point, but just curious whether or not the food skin test showing IgE positive to one or more of those common foods would change your treatment. Anyone?
Well, yeah. So can I just chime in first? I would say that since I recommended all those foods, I would say it may end up being helpful down the road, because suppose this is EOE and we do a 6-food elimination diet. If we do that and then the person gets better, then we say, okay, we got to start adding foods back in. Which foods do I add back in? Well, if there was foods that had negative skin test and some foods had positive skin test, probably would add the ones that had the negative skin test back first. So it would help me down the road, okay? I think that's always useful information to have, although we know this EOE may not be a type 1 IgE. It's more complex than just a type 1 response, a type IgE response. It's a mixed response, but still, I think that is useful information that we could use down the road.
Does it change your consideration for epinephrine autoinjector if there's a positive skin test to a food? Charlene?
Nope, I wouldn't prescribe it. There's no clinical history for such.
Okay. All right, so obviously one of the things the group wants to do, and Grant, why don't you put down skin testing for foods?
Yeah, can we put down the inhalant? I mean, there was some talk of oral allergy syndrome, so we
Okay,
probably want
we
to
could
get
say
Birch.
skin testing for foods and respiratory.
Inhalant allergens.
Relevant
Inhalant,
inhalant
okay,
allergens.
and inhalant allergens.
And if this is EOE, are there any inhalant allergens that are more relevant than others? Do we need to get dust mite? Should we just look at tree pollen because it cross-reacts with the fresh fruits? Are we thinking of anything like that? Does it matter? How does the allergens really help us in this situation?
By the way, Russell mentioned something interesting when he said fresh. And that raises the whole item of the oral allergy syndrome. This is a syndrome originally described by Claudio Ortolani in Italy, where he observed that it's necessary to use fresh foods rather than the stored or commercial variants. So the question is, do you use commercial skin test allergens, or do you want to use fresh foods?
I guess the question that I would want to know is how many of you, if any of you, would have this patient would know enough about the history to tell them to bring fresh fruit that was relevant with them ahead of time. Because typically in my practice, by the time they come to the office, if they haven't mentioned it to the receptionist when they made their appointment that was one of their concerns, we wouldn't obviously have all the fresh fruit to test. They'd have to come back for doing that. And as Joe mentioned, quite often skin testing with the standard solutions may not show adequate positives where the fresh prick to prick will. So I don't know, are any of you able to do fresh fruit without the history already and then telling the patient to bring the relevant fresh fruit?
I have a.
So although it would be ideal if we could screen these patients at all times and have them bring the appropriate fresh fruit, and sometimes we are able to do that. They'll mention it. Other times we just have to have them come back to do the testing because, as Joe so aptly pointed out, this scratch test with our solutions just don't seem to show it. All right, any other testing other than skin tests for foods and inhalant allergens that we should do on this gentleman?
How about a CBC
Okay, so CBC with diff.
with diff? Yeah.
What would be the relevance to that? How would that help us?
I sort of look for, the differential and see if there's a preponderance of eosinophils.
Okay, so CBC, capital C, capital B, capital C, with just a little W,
With diff,
DIFF.
DIFF.
Got it. What else? What else do you want on this young man?
Does anybody want, alpha gal? I mean, you did have a reaction to meat, but it wasn't very rapid. It wasn't like usually with alpha gal, it's a delayed reaction. It's anaphylaxis. It's not immediate when you're swallowing the meat. I'd probably say I might think about it, but then I probably decide it's not worth it.
Would anybody here get alpha gal? Sheila, Joan, Casteri?
Maybe not at this point, unless I had more suspicions. I think I would order an IgE. A lot of times I just like to see the sort of the allergy load on the system.
Okay. All right, well, let's go to the next slide. Let's, because want to get through this case. This is what was done on this particular patient. So if someone could read the results for us, please. Joan, you want to read for us?
Okay, prick skin test, a negative to beef, apple extract, and wheat. Mildly positive to almond and hazelnut. Strongly positive to tree, birch tree, grass pollen, and dust mite. Spirometry in the COVID-19 pandemic, office-based spirometry was not considered. CBC with diff, WBC 7,400 with 5% eosinophils. And then I can't see rest of it because the pictures of the people they're cut off on my iPad screen.
It says that alpha gal antibody was negative. So
Okay.
This particular patient, it was obtained. So how do you interpret this information? Charlene, you want to help us?
So there is no IgE-mediated food allergy. I would not conclude that even with an almonds and hazelnut. The birch tree pollen coincides with the seasonal allergic rhinitis and the oral allergy syndrome history.
What are your thoughts about the mildly positive almond and hazelnut?
Well, since there's no clinical history, or maybe I would go back and ask him if there has been any reactions to while eating almonds and hazelnut, and if he says no, then I will just dismiss it.
What's the explanation why you think it's mildly positive? Do you have any thoughts about that?
He may be sensitized, but not enough to cause symptoms. So I would not give him an EpiPen if that's the question.
Okay. Anybody else have any thoughts about that? Mildly positive hazelnut and almond?
I think that's, you
What
know, I
about
guess,
what about the strongly positive reaction to Birch? That raises the point that we made earlier about cross-reactivity with certain foods. And the question is, what foods cross-react with Birch? Or
So that's a good
on-
question, Dr. Belanti. So what foods commonly cross-react with Birch?
well, you know, I think in almost every time this comes up in my practice, what I end up doing is I have the patient pull out their phone and have them Google 3 words: fruit, pollen, and allergy. And what will pop up under Google Images is that chart, the classic chart that shows which pollen cross reacts with which fruit. And I do that because I've just told the patient how to find this information. So in the future, they can share it with their friends and family. But also it gives them access to the full list of the pollens that cross-react with birch. And so in this case, you'll see almond and hazelnut strongly cross-react with birch and provide insight as to what may be going on in this case.
So in this particular case, it's likely that the mildly positive is just cross-reactivity and not really clinically relevant, or at some point, he may complain of some oral itching when he eats almonds or hazelnut. But again, the question of whether or not to prescribe an epinephrine auto-injector would be on an individual basis. And I think most of us would depend on their history. And Joe, you were concerned, Dr. Belanti, you were concerned about his CBC. How do you interpret the CBC at this point?
Well, the eosinophils are indeed elevated. They shouldn't be this high. Although we don't usually go with percentages, we usually go with absolutes. And to get an absolute, you have to multiply the 5% with the total white count. So 10% would be 740, 5% would be
3,400 or something?
370.
Oh, yeah.
It's elevated above the normal. So this fits in line with the EOE as a tissue response may be reflected by the CBC.
Any other thoughts from the group? So let's turn to the next page. Whoops, go back one. There we go. So it sounded like, to summarize, that this patient clearly has some seasonal allergic rhinitis. This patient has some mild intermittent asthma. But most importantly, the complaints were dysphagia. And I think we are kind of operationally thinking like EOE may be high on our list from everything we've kind of put together. So what would be your next form of recommendations or evaluation if these were your working diagnoses?
I will refer him to a GI for endoscopy.
Okay, so GI for endoscopy. Does anyone have any disagreement with doing that with this gentleman?
Well, I would agree because I would be worried about an impaction, you know.
Yeah, and so far, as Sheila had asked earlier, I think there was no history of actual impaction or ER visit, but certainly that's something that you would be worried about, obviously, and in discussing with the patient what the next options were, certainly something that I think all of us would bring up. So are there any other tests that you would run other than that? Are you comfortable with the tests that we have?
Yes. Yes.
So let's move on to the next slide and let's see what the endoscopy showed. So Dr. Belanti, you want to read that for us, please?
Yes, the esophageal biopsy performed off of PPI therapy revealed greater than 30 eosinophils for high power field at the proximal and mid esophagus, and 40 to 50 eosinophils per high power field at the distal. And we have to remember anatomically, when we took gross anatomy in medical school, there are 3 strictures in the esophagus. One is the pharyngeal, one is at the carina, and one is at the distal. So these are points at which the gastroenterologist wisely did his biopsies. And these are elevated levels of eosinophils, which are consistent with the diagnosis of EOE.
Okay, so any questions about this from the group?
What is the normal? Less than,
Less than
15, I
3.
believe.
less than, okay.
So let's move on to the next slide. So it sounds as though there's a consensus that this patient has diagnostic proof of EOE. We've already mentioned the other diagnoses, but it sounds like the other treatments, for the most part, are working. Intermittent rescue therapy with albuterol, spring and fall, seasonal oral antihistamines that are non-sedating. So I guess his major chief complaint was his dysphagia. And so for his EOE, I would guess I would put EOE up there, Grant. And I guess just for time's sake, we'll leave off the other diagnoses, but we know what the other diagnoses were. What, at this point, there's a phrase, and we've used it a little bit during our discussion today, that has become extremely popular in the medical literature in all specialties, and it's called shared decision-making. And so, although a number of disease states have shared decision-making tools or aids in which you can have a discussion with a patient and then refer them to get further questions answered that they do on a laptop, and then bring back to you some of their answers as well as further discussion. There is not currently a shared decision-making aid or tool, as they're called, for EOE. So what would a shared decision-making discussion look like if, for example, I were Alex? How would you talk to me and explain to me in a shared decision-making way what our options were for me as Alex? Anybody want to tackle that? Joan, you want to try? Joan Casteri?
Well, yes, I would start to talk to him about.
No, talk to me as though I'm
oh,
Alex. Alex?
okay. Okay. Well, Alex, I think we need to institute treatment because I'm concerned that you could have an impaction where the food would get actually stuck in there and they would need to go in under an emergency situation and remove the food. So I think we need to think about starting an inhaled steroid through an inhaler, such as fluticasone. You take that at least daily initially to decrease the symptoms. At this point, we're not sure how long you would need to take it. I mean, it's not forever, but at least for now to control, improve the symptoms. We'll continue on the PPI for some, what could be heartburn type symptoms. And then we'd reevaluate you and say, come back in about a month and see if your symptoms of the food getting stuck has improved.
And as Alex, I might say to you, well, I'm concerned. You said steroids. My grandma took steroids and it rotted her bones and she had fractures and osteoporosis. And I'm not sure I want to do something that I have to take daily steroids, doctor.
Well, there's different types of steroids in the sense the inhaled ones work very locally, whether you inhale them into your lung for the asthma or you inhale them or you want to swallow them to get it in this time into the esophagus. I recall that you did have oral steroids, by mouth when you had an asthma attack years ago. And that's different because that gets absorbed throughout the body. So that's how that can affect the bones. But overall, I think, if we use the inhaled steroid for you to swallow to get it down the esophagus at this time, that the absorption in the body would be very minimal. So we would not have to be worried about the effect on the bones at this time.
Is that my only option, doctor?
It's probably I think maybe your best option at this point.
So there are no other options that wouldn't involve medication that I could try? I'm just so anti-medicine.
Well, hopefully the doctor, when he may have dilated your esophagus when he did the scope, so he may have dilated there were parts that were constricted. The other thing we would consider is avoiding certain foods which are known to be more implicated in the cause of this. Those are some of the common food allergens like milk and wheat, and there's different ideas on how to approach that, whether you would avoid a lot of the foods and then bring the foods back in, or should we avoid like milk and maybe wheat, the highly suspect foods in a case like this.
So I like milk. I drink milk every day. I drink a lot of it. Is that something that maybe I should try first instead of trying the steroid medicines that kind of scare me?
Well, there's different approaches. Do you start sort of low, and then if you're still having problems, then build up to doing more and more things, or should we try to do everything and then back off when things improve? I mean, we could approach this different ways. My idea is maybe to hit it a little bit harder initially, try to get, now that you've had the scope and you're probably dilated, we need to approach it to calm down all that inflammation. Maybe try this inhaled steroid for a few weeks, at least a month, maybe 2 months. Avoid certain foods, and then if you haven't had any problems, then for 2 or 3 months, when I see you back, then maybe we could start to back off on medication.
Okay. Well, Sheila, would you approach it the same, or would you approach it any differently if I were Alex? What would you say to me in a shared decision-making manner?
Yeah, I would explain to Alex also that
No, I'm Alex. Talk to me. I'm Alex.
if there's the steroid is one option. The other option is doing a diet elimination, and sometimes we remove many foods and sometimes we remove just a few. But in order to know if those foods are having an impact, we would have to do an endoscopy, 2 months after that food is removed to see if it makes a difference. So it's one thing that we have to consider that, this may require frequent endoscopies. And if that is not something that you want to do, the other option would be this swallowed inhaled steroid, which is another treatment option, and may not need to do the diet elimination if we go with that option. But doing a diet elimination could definitely be an option to start with. And we could start with, maybe 5 foods and see how that goes. But a repeat endoscopy would need to be done at the 2 months to see if those foods are making an impact.
So I like the idea of not having to take steroid medicine every day, but I don't like the idea of having to have this procedure that I just had done every 2 months to try to figure things out. Since I drink so much milk and I love milkshakes and dairy, can we possibly just start off difference, or do I still have to be scoped?
Well, milk is definitely a food that is known in this condition to be a factor, and the testing is not always, unfortunately, not always very helpful with milk specifically. So that is definitely an option. However, I would still advocate for an endoscopy to be done at some point to make sure that we're actually seeing an improvement in the in the esophagus objectively. And if that doesn't seem to make any difference, we would have to consider eliminating more foods. And if that is not an option for you, then we can talk about the swallowed corticosteroids.
So Charlene,
Yes.
talk to me as though I'm Alex in a shared decision-making manner. How would you do it different, or would you say pretty much the same thing?
Actually, it's totally different in our practice.
So I'm Alex. Tell me in a shared decision. Talk to me.
Okay, Alex, I think your options are to take a medication that contains steroids, and you will have to take that to minimize the inflammation in your throat, versus avoiding many foods that can aggravate your symptoms. As your allergist, I think this is important, but because you also have a gastroenterologist who confirms your diagnosis, it would also be good for you to hear their input as to your treatment.
So it sounds like the whole idea of skin testing me for foods probably didn't make a whole lot of sense to me as a patient, because it sounds like you guys aren't that interested in the elimination of foods anyway. It sounds like the steroid thing I need to swallow is really the most important thing, is what's coming across. But I'm real steroid phobic because of my grandma, so I'm not sure if I'm going to stick with that plan. I may try it, but because I don't want food to get caught in my throat, but I certainly don't want to end up in the emergency room. But it just scares me to take a steroid medicine every single day. So Dr. Belanti, talk to me as Alex in a shared decision-making manner. How would you approach Alex?
Well, my approach would be a little bit different. I agree with all of the discussion on the therapy. But before I would talk to you, Alex, I would start first with some discussion of why this occurred and what is the pathology in simple terms that you could understand. First of all, the cobblestone appearance that we saw in your pharynx, in your throat, probably is similar to what's going on in your esophagus. It's called allergic inflammation. And by that, we mean the body's reaction to a foreign configuration, in this case, to an allergen, probably a milk or the cross-reacting Birch that gives you a reaction of tissue. And in that tissue, there are these cells that are called eosinophils, and they're elevated. And when they're there, they cause the symptoms of dysphagia and swallowing. Steroids, your concern about steroids is valid, and we would use it discriminately. And the reason we use steroids is because eosinophils are very uniquely sensitive to steroids. This is one of the first descriptions made in the 40s by endocrinologists, that you can actually destroy eosinophils with steroids. But in addition to eliminating the foods, which is the cause of the condition, we would only use the steroids discriminately. And so your concerns about your grandmother's problems we'll take into consideration, but we want to assure you we would use them appropriately. There's a new phase of treatment in allergy and immunology now that destroys the eosinophils, not by steroids, but by some very modern biologics, which are directed against certain cytokines, such as IL-5 and IL-5 receptor. And these might also be used. And I'm not too familiar, Alex, with it, but I'm gonna go to the literature and find out and do a PubMed search and get back to you and find out what is going on with the biologics, if this could be another option that we could use.
Well, thank you, doctors. I appreciate your approach and your explanation, and I'm going to go to Dr. Google and read up on all this myself before I decide to take any medication, and then I'll check with my parents and see if they agree, and then maybe I'll try some of this. But I certainly wouldn't want to quit drinking my milk. I love my milk, but if I have to, so that I don't choke on my meat, I may have to make some compromises. So it's the top of the hour. It is 9:00. So let's turn to the last page, which is our learning objectives. Thank you, Grant. And so it says, after completion of today's program, which includes the PBL plus the post-PBL lectures by Karen Letman, The participants should be able to initiate an appropriate evaluation strategy for EOE, eosinophilic esophagitis, based on history, endoscopy, and biopsy. Should be able to initiate the appropriate therapy and follow-up choices based on clinical findings and patient needs in a shared decision-making manner, and benefit from a shared decision-making aid when and if there is one that's available. Discuss medical and dietary treatment options for eosinophilic esophagitis. And I think we certainly have completed these objectives, but they will have an exclamation point dotting the end of Karen's post-PBL 2 PBL lectures. So I want to thank each and every one of you for participating today, for jumping in and giving your points of view and your great discussion that you did. I certainly embrace and love the opportunity every year that I've been given the opportunity and the honor to come to Eastern Allergy and facilitate new PBL cases each year. And I hope you guys got as much out of this as I did listening to your opinions. So again, as I said, I always take some pearls away from each and every time I facilitate a problem-based learning discussion. I learn from my peers like each one of you. And so thank you all for your participation. And I hope you enjoy the rest of the conference and Karen's post-PBL lectures.
Thank you.
Okay, thanks. Thank you so
I
much.
would
Thank
like
you.
to say thank you also to all of you. I've really enjoyed this session, and because I've learned something. I've learned something from each of you, and I hope that you learned something from me. So it's a bidirectional PBL. The other thing I'd like to say is to Ray and to Russell, this is an exceptionally good way of doing PBLs in the future. I have a much better reception of hearing what's going on in a much improved way than we did in the older ways of the big lecture halls, and where I don't hear too well because of my age. And but now I hear very well. And you might want to give this some thought, Ray and Russell. So when we do this in the future, we might have not only the person-to-person type PBLs, but also I could go to my room and Zoom or go someplace and hook up in the same way we did today. So this
maybe give people options, Joe.
Yes, I'd give them options, and this is an excellent way of doing it. And I thank you, Ray, for bringing the PBL to us over the years. I've learned much from you as well.
Well, thank you. It's been an honor working with you. Thank you so much. All right. Well, you guys got some time to get some
Thank
coffee and then get to Karen's lecture on time. So everyone, please stay safe, and thank you so much.
Bye.
Thank you.
Grant,
Thank
thanks
you.
for all your IT help.
you all.
Appreciate
Yeah,
it.
of course.
Couldn't have
Thank
done it without
Bye.
Grant. Thanks again, Grant.
Yeah, of course. All right. Great working with you. On the
Did you
meeting now.
record today?
Yes, I did.
Okay. All right, good. So don't forget to let me in on the recording at some point.
Yes.
Send me a.
Yeah, I'll upload them tonight.
All right. Hey, there's Dr. Buckstein.
Hi, guys. I'm spying.